Okay. So we have identifying CNS symptoms also is very important. Somebody comes with headache. All headaches are not necessarily because of CNS diseases. CNS diseases will have headache, but even sinusitis can cause headache. Your CSOM can cause headache. Simple malaria you can have come with headache. So therefore, you should identify which is the CNS symptom. Which is a CNS symptom? Headache is a CNS symptom, but all headaches are not necessarily because of CNS diseases. So these are the differentiating points you should know. And conversely, there are CNS symptoms which are not related to CNS diseases, which are related to some other diseases. For example, patient comes with seizures to you. Okay, you think seizures is because of CNS diseases. In fact, this patient may be having hypoglycemia. A diabetic patient, he has taken insulin and he has not eaten for some reason. The patient comes with seizures. You think that it is a brain disease. Poor brain is innocent, intact. Whereas the seizures are because of hypoglycemia. So you should be able to identify what symptom which is looking like brain, CNS disease is not is a secondary to some external outside CNS disease. So you should be able to differentiate between these two things. And another very important, whether it is a functional symptom or a really an organic symptom. Many times functional symptoms, organic symptoms, like for example, neck rigidity, for example. Neck rigidity is a sign of meningeal irritation, meningitis. Okay. So some people will have an anxious patient, very anxiety, restless patient. He will hold the neck tight and as if there is a rigidity. So you should be able to identify, is it an organic disease or a functional disease? A psychiatric patient may keep the whole body rigid, and there you may see, suppose he must have had a fever one day, and there is a neck rigidity. So you think it is fever, neck rigidity, you think it is meningitis. In fact, it is only a psychiatric patient, he is keeping the body rigid voluntarily, deliberately. So that is, again, when it comes to functional and organic, seizures, for example, seizures can be true seizures or pseudo seizures. True seizures or pseudo seizures. Sometimes we do get young people, a boy or girl, just before the examination, or some family issue or husband-wife fight, or a love affair, or whatever it is, whatever some family issue or some psychological disturbance in the family, they pretend that they are having seizures. They pretend that they are having seizures. This is called attention-seeking behavior. An attention-seeking behavior, they come to you with a history of convulsions, a movement, clonic movement. So you should be able to identify whether it's very important to differentiate between the pseudo seizures or true seizures. Sometimes it is very difficult. Sometimes a true seizure may look like pseudo, or pseudo seizure may look like a true seizure. So here we should history. If you take the history, there are a few important history points where if patient is falling down and sustaining injury, it is 99% is a true seizure. Versus a pseudo seizure patient who's an attention-seeking behavior patient, he will fall down, but he will manage not to injure himself. So fall with injury is an indication of true seizures. Same thing, if somebody is biting the tongue, it's a true. No biting the tongue, it may not be a true, it may be a pseudo seizure. Same thing, somebody is bedwetting, passing the urine, passing the stools in the clothes. These are all the points in favor of true seizures. Pseudo seizures we don't. And pseudo seizures patients, they make sure that everybody is around when they are having seizures, and they don't seize in the night. So they don't seize when they are alone walking on the road. So they manage to create an atmosphere where everybody is around and want to grab the attention of your family member. So these are the differentiating point between pseudo and again, there is a gray zone also. You should be very careful. However, even if a patient is looking at a pseudo seizure, you should rule out a possibility of true seizure by investigation. So all neurological diseases Even the tremors, sometimes the anxiety patient will have tremors. It need not be always Parkinson's disease. So you should be able to differentiate between functional and organic disease-related symptoms. So therefore, I said best thing is spend good time. The patient is able to give you some time. The patient is not having any emergency. Please do spend a good time. Sit on a chair and have a tete-a-tete, head-to-head or one-to-one, tete-a-tete, one-to-one discussion with the patient. Doctor and patient should sit together and talk to the patient. And sometimes the patient is not able to give you the proper history. You take the help of family members. So history. Again, I'm repeating you. The history is very important in neurological exams. And history also will give you the site and the pathology also sometimes. The patient says, and now I've got seizure. My patient has a seizure, and he's got history of fever for the last 15 days, evening rise. So he is not only telling that there is a seizure, he is also telling that there is a pathology which is likely a tuberculosis meningitis. So history will not only tell you the location of the lesion, sometimes also the pathological disease also. Suppose somebody suddenly, like this, my patient today, somebody had this sudden problem. He was all right. Suddenly he had a hemiplegia. So it is a vascular pathology. So you know the pathology also. So in the history, you get all these points. So that's why you have to spend enough time on history, and a focused, targeted examination should be there. You have to target. And remember, CNS, after CNS examination, the disease can be elsewhere. Patient will have stroke or other things, but disease is elsewhere. Like mitral stenosis, there could be cardiomyopathic stroke, and patient may be having hemiplegia. We are examining the CNS, and you are diagnosing the case of hemiplegia. But if you are forgetting to examine the heart, you will mix the bus. You will miss the origin of the disease. This is the culprit. Your mitral stenosis is causing cardiomyopathic stroke. So always it is mandatory to examine all remaining systems, the whole body, even when the patient is having a pure CNS disease. That is an important thing that you should remember. So coming to anatomy again, there are billions of nerve cells in the brain, billions of nerve cells in the brain, and they crosstalk with each other with the dendrites and axons. So they connect, and throughout brain stem, cerebellum, spinal cord, and the peripheral nerves. All these in a coordinated way. These billions of neuronal cells are there, which crosstalk with each other, and the rate at which the nerve conduction takes place is in microseconds, or milliseconds, or microseconds. It just happens like that. So the nerve conduction is such a wonderful electrical conduction. So as you know, the nerve cells are also called the glial cells. There are mainly three types: astrocytes, oligodendrocytes, and the Schwann cells. Schwann cells are usually covering the nerve sheath, the myelin sheath, mainly astrocyte and oligodendrocyte. So why you should know about all this is because there are certain tumors, there are certain diseases which specifically target these cells: astrocytoma, oligodendrocytoma, dendroglioma, glioblastoma. All these, they arise from these specific cells. So they all work in a complex network. The nerve fiber, the cells are complex network, and at the same time, the blood supply also enormous. Brain receives about 20% of the total cardiac output, 20% of the cardiac output, and it has got a blood vessel connection, microvascular connection is so well knit with in parallel with the nerve supply. Each nerve requires a blood supply, and blood vessels also require nerve supply. That's the beauty of the functioning.